Welcome to Healthcare Musings, a podcast dedicated to the discussion of critical care and healthcare in general. Here's your host, Dr. Hesham Hasabala.
All right, everybody. Happy to have you with me. I am delighted to have on the podcast today Dr. Ben Solomon. He is one of my partners out east and great guy. I've known him for many years, and I am so happy that he is able to join me in honor of Critical Care Awareness and Recognition Month, which is the month of May, just to talk about critical care, why he went into critical care, and just and then we can take the conversation from there. So without further ado, Dr. Solomon, please introduce yourself to the audience.
Sure. My name is, first of all, thanks for having me. And I have to start out by saying it's truly an honor to work with someone of your personal caliber. You always inspire me, and I really feel great being part of our organization. But knowing that there are people like you part of our organization, I draw on that inspiration every day. So thank you very much for that.
That's very kind of you, and the Zelle will be forthcoming after the shows.
No, it's true though. It's true. Anyway, so I'm Ben Solomon. I'm a pulmonary and critical care intensivist. The short rundown of the CV is born in New Jersey, in Bricktown, Point Pleasant, actually born in Neptune. And then my family relocated when I was 10 to Florida, the Clearwater, Tampa area. Spent my formative years down there. That was middle school, high school, and college. And then came to Philly essentially for I did postgraduate, 3 years of postgraduate training, then med school at Hahnemann, then residency at Hahnemann in Philly, and then pulmonary critical care and sleep at Temple University in Philly, and been here ever since.
That's awesome. I'm not sure that I've actually formally introduced myself to the audience ever since starting the podcast. I was born at Rush University Medical Center, where I did my medical school and training.
How about that?
Yep. I think I mentioned that perhaps 50 times during my medical school interview, that I was born there. Like I kept saying, "Did you know that I was born here? Did you know that I was born here? Did I mention that I was born here?" And so I did my medical school residency fellowship in pulmonary critical care at Rush University. Went out in private practice for 7.5 years doing the traditional classic office inpatient pulmonary critical care, all in one stop shop for 7.5 years, and then the opportunity to run the critical care program at Rush in Aurora, which is the second largest city in Illinois, came up. I'm in my 12th year now, and I couldn't pass up the opportunity, and I've been with Sound ever since. So I really enjoy it, and the reason why the group that we're in is so special is because I get to work with people like Dr. Solomon. And so I wanted to, in honor of Critical Care Month, I just wanted to kind of get your sense of what was it that led you to the ICU?
It's a very roundabout story. So leaving Florida, I'll step back, right? We always say that it is our experiences that shape us into the people that we are. And not to be maudlin, like yourself, I had some family tragedy early on. My stepfather, who I absolutely adored, he died when I was I think I was 21 or 22, and during that experience, I found, this was in Florida, I found that the physicians actually, and he had a survivable illness, but he was a World War II veteran. He was about 15 years older than my mother, and dignity was his most important thing. And being a hospitalized patient, or a patient at all, was very undignified to him. So he had a survivable illness. He was in heart failure. I know it now what it is, but he needed a little dobutamine or this or that. But ultimately, he had gotten intubated. And right before he got intubated, he said to me, he told me, Benny, he's like, Benny, why are they doing this to me? Why are they doing this to me? Don't let them do it to me. So, I had to go back, because I was in grad school then. I wasn't in medical school. I was in grad school, fighting for my way in. And he had gotten intubated. So I went back to Florida, and you know, this there's a spiritual part of this, but anyway, I went back to Florida, and he ultimately, we withdrew support on him, and he ultimately died.
Wow. I'm
His
so
illness.
sorry to hear that.
Oh, it's okay. It's actually a longer story than this, but his illness, as I say, was survivable. But I felt that the physicians just didn't. They're like, oh, it's some old dude and whatever, and he smoked and kind of got what he deserved. And I really didn't get the sense that they cared as much, at least as I did. And then a year later, my father, who had been stricken with Parkinson's my whole life, I never knew my dad without Parkinson's, and he was institutionalized. So a year later, he died, which
Oh my God.
was not as traumatic as you might think, because by that time he had suffered all the sequelae of Parkinson's. He was demented, contracted, institutionalized. So it was kind of like a blessing, if you will.
Mm-hmm.
Anyway, so fast forward. So I have that experience. So I say, you know what? And I felt all along my stepfather's path, if somebody maybe would have intervened before he got to the ICU, things would have been better. So I said, you know what? This is South Florida. It's underserved. I'm going to go be a family doctor. Now, I liked my family doctor as a kid growing up. And I said, I'll come up to Philly. He was a graduate of PCOM. I said, so I'll come up to Philly maybe, and I'll be like him, and I'll go back and I'll treat, family medicine. Because I like knowing a lot about a lot. And in fact, I'd have to say probably one of my greatest faults is I really don't know my limits. So I kind of enjoy, like I like to know a lot about a lot. So come up with the intention of going to PCOM, actually, which is, I'm sorry, Philadelphia College of Osteopathic Medicine.
Mm-hmm.
But my grades were terrible, 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 terrible. And all through college, I was a biology major. I'd wrestled in high school. I was wrestling in college. I figured, I'll be a bio high school teacher, wrestling coach. It'll be great. But I always had this thing with my stepdad, because he really got sick my last 2 years of college. And so anyway, so I find my way up here. My uncle, who's a college professor here in Philly, put me up in his place at the main line and helped me a lot to, bought groceries for me, made sure I had all the support I needed to just study in grad school and try and get med school. So anyway, so getting med school, doing my rotations. I'm going to be a family doctor again, go back to Florida and treat everybody. But what I found was that I did not like obstetrics and gynecology. I realized that nobody's bringing me, I'm not doing appendectomies and cholecystectomies. And actually in my lifetime, my stepfather had his family doctor take out his gallbladder. So I remember because I was,
Really?
yeah, yeah. So
Really?
I
Wow.
had, yeah, no kidding. And this was in New Jersey, in Point Pleasant, actually. So
Wow.
I had to be with my stepdad at night, to make sure he was okay.
Yeah.
So my head, I'm like, oh, I'll do some appies and some colies. It'll be a great life, whatever. But then you come up here, you're like, oh, no way, I'm not doing that. So that ruled out general surgery, and I loved pediatrics, but it was, as you well know, it can be quite devastating. And
Absolutely.
so I spent some time in the NICU as part of my pediatric rotation, and that was the first time I was like, wow, I love this. But what I loved was the critical care, the patient population. It was, and I'm a student. We don't have those emotional mechanisms in place to deal with some of that stuff. So
Right.
like, oh, this would be tough. Having to counsel parents specifically through, which I'm always, so sorry that you had to go through that, counsel the parents through that process. So
Oh, thank you.
as things came out, I'm like, well, I'm down now to taking care of adults. And if I'm going to take care of adults, then I should do general internal medicine. And I loved internal medicine because I always felt the internists they were the true diagnosticians. They knew the medicine. They were the smart people. They got the fascinating cases. Awesome. I'm all in. During my time, though, as going through internal medicine residency, that's when the shift started to happen of the HMO and the utilization managers. And does the patient really need to be here? And you got to fill out this paper and that paper. And I just remember thinking to myself, I did all this work, like 4 years of high school, 4 years of college, 3 years of grad school, 4 years of med school, to be like having somebody ask me if my patient really needs to be in the hospital, and it would anger me. So, but I still had this love of critical care, you know, because from med school, and then I got into I did my surgical rotation at Crozier Chester Medical Center, which is in Chester, just south of Philly. Another, you know, a lot of another metropolitan area, if you will. But I went to surgery the first night, and in that brick cell block, I didn't like it at all. So I realized pretty quick that I love what the surgeons do, but that wasn't for me. But at the time, I could give my OR time to my medical student, my medical school buddies, and I would sit in the ICU and take their ICU time because they hated that because they really wanted to be surgeons. So I'm
Yep.
like, I'm a good guy. I'll take your ICU time since you hate it so much. I'll take one for the team. So in my third year of medical school, I spent, 3 months in SICU, and I did 100 central lines, 5 or 6 chest tubes, art lines, all the stuff we do, the sick patients, the physiology is like, this is it for me. Absolutely, this is it for me. And then coupled that with the experience of the UR when I was in a residency, you could be an internist intensivist, but then once the UR people started coming around, I was like, you know what? I need to be in a place where it's all business, all medicine, all physiology, no questions about it. And that really helped to solidify, the mechanism of what I was going to do. But the passion is I desperately needed to help families and help patients through the darkest time of their lives. That really became my passion. And now I'm a little older and I can reflect on that and say that it is my passion, and I help people, and I really wanted to help them when they needed it the most. But also I believe it wasn't as altruistic as I think, and through that help I have felt better about some of the things that happen in my life, and it's taken the sting out of what happened to me because I can take those situations, draw upon them emotionally, connect with the patients and their families, and help them through. So that is how and why I got to critical care.
That's fantastic. I hear a lot of my story and your story. It's I remember in third year it was interesting. It was between anesthesia and internal medicine going on to critical care. So when I was in medical school, I just loved the ICU and I loved pulmonary medicine and the physiology and the thinking part of it and all that stuff. I hated pulmonary pathophysiology in medical school because our teacher couldn't teach it. All you could do was write me a graph, draw me a graph. I'm like, don't draw me a graph, bro. Explain it to me. He just couldn't do it. But I gravitated to it as in my third and fourth year, and it was my fourth year. I was in between anesthesia and critical care, and I was in the I did anesthesia for 6 weeks, and I just couldn't bring myself to do it. There's something about it. I just couldn't. I needed more patient care, more patient interaction. So that was my decision. And right as I was going to put the match in, the chief of surgery came to me during my anesthesia rotation and told me, "You should be a surgeon." And he just convinced me at the very last minute. So I applied the very last minute, and I did rush surgery number one, and then I did rush internal medicine number two, and then all the other medicine, beyond. As soon as I turned to my match list, I realized I don't want to be a surgeon. And I was toxic going to match day because I thought for certain he ranked me to stay in surgery. And I kept trying to convince myself, oh, I could be a surgeon. I hated it. I was so scared. And I opened up the envelope and I saw rush medicine. I was so happy. So happy. And then later I asked, we kind of like, what happened? Like, why? Kind of in a roundabout way, because I was still on my anesthesia rotation, and he's like, Hector needs to know what he wants to do. So apparently he must have found out that I ranked medicine down the line, and I'm like, okay, whatever. I didn't want to be a surgeon anyway, but like, you think I'm gonna hang my entire future on you and your whims? No, I'm gonna have a backup, obviously.
Yeah.
And then I was all in pulmonary critical care. As soon as I walk in the ICU as as a resident, I knew I was home. I just love it there. It fulfills the internist in me. It fulfills the surgeon in me. I have to know, I have to know everything, right? I really feel critical care is the only time. I don't mean to disparage my colleagues. It's the only field where I am a doctor, right? Where I care for people, the whole person. I have to know a little bit about cardiology, a little bit about GI, a little bit about endocrine, a little bit of, and I do procedures like a surgeon. I love it. I love it. And I've been in love with the critical care ever since. Just like you, it gives me the opportunity to I use the word minister to families, and especially families, when they're facing the worst moments of their life. And to be able to help them through that is, I say I win, quote unquote, whether the patient lives or dies. They live. That's why I became a doctor. We help them, conquer critical illness. But if I know that they're going to die and I can give them a good death, I'm just as happy.
Yeah, I think it fall, you brought a couple of points, I want to touch on on what you just said, but when I was going through, I didn't like pulmonary either. I thought I just want to be an ICU jockey, right? And I
Right.
remember my mentor saying to me, you have to do pulmonary with critical care because you have to understand the ventilator and the lungs. And I was going to do anesthesia critical care because I just didn't want to do pulmonary critical care. But ultimately, now I love pulmonary, right? And all the physiology and everything. And it does go, very, very well together. But, about ministering to the patients, I say in critical care, we take care of the patients to the maximum of our capability, 150%. And if care is restorative, then we will work 150% to restore them. If care, however, is comfort, then we will work 150% to comfort them. And
I love that.
the effort is the same. The treatment plans are different. And that's one of the things I try to explain to the families when we talk about withdrawal of support specifically, is to explain to them this is not an absence of care. It's still very aggressive care, but it's
Mm-hmm.
aggressive comfort care, not aggressive restorative care. And
I love that. I love that. I'm gonna start using. I'm gonna steal it.
sure,
That's
sure.
fantastic. No, and you're exactly right. I mean, that's fantastic. I've never thought of it that way. That's amazing.
Yeah, we're not, and I've also come to understand, we're not determinants of outcome. So when I first started, I thought, in my own arrogance, I thought I was a determinant of outcome because, we all train in academic places, and certainly, certainly I can get somebody a heart transplant. I can get somebody lung transplants. I can get somebody a renal transplant. I get somebody a liver transplant, right? So, and nowadays, obviously, we have LVADs and ECMO and life support machines and dialyzers. So I have no, when I first came out of fellowship, I thought, man, I can just do anything and everything. But then I learned my place in the world, and I took a lesson from the Bhagavad Gita, right? And the role of that is to discern your dharma, do it full out, leave it up to a higher power, whichever one you believe in, and let go of
Mm-hmm.
the outcome. And then that's what I realized, that I'm not really in the outcome department. I'm in the effort department. And as long as we give the maximal effort, however the outcome is, my conscience is clear because we've done everything we can.
That's very telling and very true. COVID, I struggled with the outcome part. And I actually asked my pastor. I asked him, I know that I'm not in control of the outcome, right? Yet why do I feel so bad every time I lose a patient? Is there something wrong? And he said, no, no, no. That feeling is noble. You feel bad. You couldn't help your patient. And um, but really, like if I really understand and internalize that I'm not in control of the outcome, then the pandemic shouldn't have been as devastating as it was to clinicians. And at the same time, we want to help our patients. We want them to conquer critical illness and to help them feel better. And it's just I never thought that how hard it would be to lose one after another, after another, after another, after another, and doing and fighting like hell every single time, you know?
But that's the key, right? That was the key, at least for me. That's the key to survival. As a clinician and as a human, if I did everything in my power and the patient still died, then that was the universe, and I couldn't turn it around. And of course with COVID, it was, we're the fire people, right? So every time a patient's in respiratory failure, respiratory distress, needing to be intubated, before we had PAPRs and before we had all that stuff, every time I ran into a room, I would look at the patient. Is this the patient that's going to kill me? Is this the interaction that will give me COVID and I will die? And there were a couple
Wow.
times, we had these young kids. I still think I'm really young, but at 55, unfortunately now the patients are, starting to be a little younger to me. But anyway, you run into a room of a 30-year-old or a 40-year-old. And I remember running into the room of this 38-year-old guy with 5 kids, and there was no PAPRs, there was no nothing. He was going to arrest, and there were no masks or whatever, and I put on a quick mask or whatever, and I went in, I intubated the guy, because back then we had the data. It's like 10 minutes at X% of concentration or whatever. I'm like, listen, I can tube this guy in 60 seconds and I'll be out of there. So
Yep.
I ran in and I'm intubating this guy, and I remember thinking to myself, I hope if I die, it was at least so that he could live and see his children. And so that was kind of the wear and tear, I think, on us, right, when we see these patients. But yeah, the exasperation of almost knowing the natural history of the illness with no real tools in the toolbox was very challenging. And I think that
Yeah.
I'm a yogi, right? So I practice yoga and I teach yoga. And I think I really fell back during that whole team. I really fell back on the yoga teaching and certainly the yogic path, but this concept of just let go of the outcome, right? We did not make any choice or decision that put the patient in that realm, and for what it's worth, nor did the patient, right? This is just something
Right.
that happened to them, and all we could do is everything we could do and support the patient with all the medicine and science that we have at our disposal. But the outcome was going to be the outcome, and the higher power was deciding it. I was not.
Wow. No, I, yeah, I agree. I mean, that's going to be, I'm going to take that to heart. That's going to be a challenge. Let go of the outcome. Because all I see is the outcome. I mean, that's that. And as I think about that, I mean, I think you're right. It's just easier said than done. It reminds me of, actually reminds me of Star Wars, where Anakin was talking to Yoda about his dreams about his wife, and he said, "Learn to let go everything that you care to lose," which
Yeah.
is
So
much
that
harder, easier said than done.
so that actually is a yama from the so part of the yogic path. A part of the Eightfold Path is something called the yamas and the niyamas. A set of is a code of ethics and a code of restraints. So what you just talked about is not only letting go of the outcome, but it's a parigraha, meaning non-greed. Let go, give everything that is important to you, because the root of all suffering is grasping and fear.
Is the fear of loss?
Well, no, just it's grasping. So, grasping, for example, we're physicians. We grasp to give our patients life and not have them die. We grasp for that. And it causes us suffering when we can't get the patient back. The patient in the bed is grasping for health. So we think they're suffering because of the physical ailment, they're having pain or the lung cancer or whatever, but they're grasping to life. Like, I'm not ready yet. The families are grasping also for the life of their loved ones. So that all this suffering is created by grasping. And if you just play that forward in terms of, well, letting go of things that are important to you, like let's people have real fancy cars, for example, but
Yeah.
they drive around in fear all the time. Oh, somebody's going to ding the door, or I'm going to get in a car accident, or somebody's going to hit me. And it, as much as they enjoy the car, it creates suffering within them, right? There's a suffering to, oh, I have this nice car, I better put the cover on it, I better do, and that's So that's what I mean. Like all these things, especially during COVID, I really fell back on some of the yoga philosophy, if you will, and teachings. You know, those people were smart, 5,000 years ago. They didn't have TV, they didn't have
Yeah,
cell phones, and they just sat around and thought all day. So anyway, that's kind of how I approached, the COVID, and that's how I approach my care now. And I tell the patients' families outright, I am not determinants. I'm not the determiner of the outcome. I will work very hard. We will do everything we can to save your loved one, but I do not determine the outcome.
that's awesome. I mean, I think if I should, if I can learn how to do that, I think that would be. I think that would be better. That's something that I'll definitely take to heart. I always, you and I are both on shift, right?
Yeah.
We're recording this on a weekend,
Mm-hmm.
right? So we're here in the hospital. We're where I'm at in Chicago. It's gorgeous today.
Gorgeous
Uh,
outside, and we have this
yep,
nice little courtyard with ducks and stuff.
yep. It's absolutely gorgeous outside. And so, like, I'm having a I'm having a hard time being cooped up. At the same time, I am, and I want to see what you think. I mean, I am incredibly grateful to be a physician. I really am. It is the only thing I've ever wanted to do since I was a kid. And so with all the difficulty, with all the annoyances that come with it, I am super grateful. I could not see myself doing anything else at all. At all. What do you think?
So I think the job picks the person as much as the person picks the job. My own background is I grew up largely in a mobile home park in South Florida. Worked in flea markets. That was kind of like the family business, so to speak. So,
Really?
yep. So really, everybody talks about trailer trash and stuff, and I always think, well, that's me, working in flea markets and stuff. So to your point, I love my life. And from a time I was a little child, now my Uncle Max Rubin, was a PhD nutritional biochemist at the World Health Organization.
Oh, really?
He,
Wow.
yes. So from a time I was a little boy, he was my great Uncle Max, actually. He was my grandmother's brother. And I always went and spent time with him, and he'd take me to his lab and stuff. And he did, he did a lot of amazing work. One of the things he helped elucidate actually is we call it R protein, but when they discovered it, they called it extrinsic factor. So he was
Mm.
involved in developing nutritional programs for the Army. And one of the things he did was try to understand the metabolism of vitamin B12 and why some of the troops would get pernicious anemia and some would not. And so, intrinsic factor was known, but nobody knew about extrinsic factor or our protein. So he helped discover that.
Wow.
The other thing he did actually, he worked on chickens. And the hypothesis was that there's a lot of energy that goes into making feathers of the bird. So he developed featherless chickens so that all the energy could go into the meat development so that they could grow these chickens real fast, deploy the troops, grow the chickens real fast, and have food for the army. Anyway,
Wow.
super smart guy, like a real pioneer of his time. But I spent some time with him in his lab, and I'd always wanted to be a doctor, And he bought me when I was 6 or 7. He bought me this book called Gray's Anatomy. This thick
Oh,
paper,
yeah. The great. Oh, wow.
yeah, with like the white cover and the white. And anyway,
Yep.
and he said, "Listen, you won't know what to do with this now, but maybe in the future you might find this handy." And I still have that book on my, he's long since passed, but I look at my Gray's Anatomy and I always think about Uncle Max. So anyway, there was this inkling. I always wanted to be a doctor, always wanted to be a doctor, but we had a family business. And as I told you, my stepfather was very ill. So I couldn't leave home because I had to be home every Friday, Saturday, and Sunday because that's when we worked in the flea markets. And then my stepfather needed help, and that's kind of just how it worked out. Also, I was not mature. I was not a mature student because I worked every weekend in the flea market. I would party, man, like because I had Monday through Thursday in college and I was going to whoop it up because I had to go home every weekend. And
Yeah.
consequently, I had a terrible GPA. I was a terrible student. I had no emotional maturity. So this dream started to just whittle away. Like, dude, there's no way you're getting in med school. No friggin' way, on and on. And so it wasn't until my junior and senior in college where kind of like snapped to it, if you will. But it was a fight all the way. I mean, 3 years of grad school with no guarantee of getting in med school, and then 3 years, and then 4 years of med school. Then the thing about not being a surgeon was it's 7 years after graduation. I thought, oh my God, I couldn't do that. Sure enough, I trained for 6. So, like it just works out that way. The job.
Yeah.
And I always say, like, being a physician, it's not, if you don't love it and you're not passionate, it's not survivable. It's just not survivable.
100,
It's not survivable. Say,
100%.
like, okay, don't worry.
100%.
You won't have a life. You can't own a home. You can't buy a car. You'll have no money. You'll live like a pauper for all these years. Back when you and I trained, you work 38 hours, then off for 8, then back for another 38. Because, I came in at 7 in the morning, worked all day, worked all night, worked all the following day till 6 or 7 at night, went home, caught some rest, came back at 6 in the morning to do it again. And so 130 hours a week. Like, nobody, my friends thought I was insane. And I'm seeing, they're like, hey, I had a baby. We just bought a house. And they're going on vacation. And I'm like slugging it out in the library on the corner of Broad and Vine in Philadelphia, thinking like it's like 2:00 in the morning on a Friday night, and I'm studying because I got to go home. So I'm going to come back and study at 6 in the morning.
Yeah.
Like, what kind of friggin' life is this? But I always, every time I studied, I always said to myself, one day this piece of information will be useful. One day I will have a patient that will need this piece of information. Now, if I may back up, the reason I worked really hard because I'm not the innately smartest person, right? I don't have this great IQ and all these megabytes. So my whole life, whatever I did, I always made up for it with perseverance. For example, I was a mediocre wrestler at best, very mediocre technical wrestler, but I could work really hard and be in extraordinarily great cardiovascular shape. I could outlast my opponent based on cardiovascular conditioning, and that's how I won matches, not because I knew all the moves. So now I'm in grad school. I mean, this is relevant. So I'm in grad school, and the thing was you had to get at least an 80% on all the tests in order to keep making it to the next section, next segment. I went to one of these programs. It's like where you do all this graduate school work to get better, to get in med school kind of thing.
Right.
So I was in the first year of this, and I was in pharmacology class. And there's a point about all the points will be important. So I'm in pharmacology, take the test, didn't hit the mark. And this was the final. And if I didn't make this, then I have to go home to Florida. So I didn't make the mark. And, I'm all sad. I'm like, all right, my run is over. I'll go back to Florida, whatever. And I said, you know what? I'm going to go talk to the professor. I'm already out. What do I have to lose, right? They can't kick me out. I'm already out, so it can't get worse.
Yeah.
So this guy's name was Benjamin Chernick, and he wrote the book. And the test question was about THC and its mechanism of action. Mm-hmm. And it turned out that there was a typo on one of the responses. So there really was no right answer. There was a best answer, but no right answer. And the question I answered wrong was, THC, needs to be lit and vaporized and all that kind of stuff and the biochemistry of it. So I went to his office and I said, listen, you didn't have the right response. And I come from college. I'm an education minor, right? Because I was going to be a high school biology teacher. So I said, listen, I know all about test validity, question validity. The question is not valid. Therefore, it must be thrown out. And if he did that, then I get the grade I need. And a bunch of other people are going to do well too, whatever. He said, no. He said to me, you should have known better that was actually the right answer, but I made a typo. And I said, that's not my responsibility. Proofreading your test is not my responsibility. Knowing the material is, and I know the material. I memorized your book. Like, I know what the answer is supposed to be. Mm-hmm. So we went back and forth for like 40 minutes. And he's like, well, you know how I feel. So, okay. Well, I said, thank you for listening. It's all great. So I get up and I'm walking to the office door. And I just about get to the door, and the guy, he's in a swivel chair like this, and he swings around and he calls, he says, Dr. Solomon. And I swing around. He said, I'll tell you what, I'll make you a deal. I said, okay. He said, you want a deal? I said, oh, I'd love a deal. I'm thinking, wash car, repaint the house, like whatever. He said, I'll tell you if you, I will give you that question if you promise me one thing. I said, what is it? You need to promise me that you will work as hard for your patients as you just did trying to convince me that this question was inappropriate. And I said, I can absolutely guarantee that. And now it's, I mean, I get a little emotional. That's 30 years later. It's more than 30 years later. I remember that interaction like it was yesterday, and I advocate for my patients and I fight for my patients. So getting back to your question, I love being a doctor. I am absolutely grateful for this opportunity. Not only it's not even for me. I think it goes back to the little boy or the 20-year-old who lost both his fathers, right? I want to be able to give people back their family members for whatever amount of time so they don't have to feel that pain or
Yeah.
at least not feel it today.
That's fantastic. I mean, you mentioned the long hours and everything. I agree with you 100%. There's no way that you could get through the slog of training and the difficulty if it's not in your heart, if you don't have the fire in your heart. And I was just talking to my nephew yesterday. He just got into Wayne State Medical School, Wayne Medical School, whatever. And he's like, "Why am I?" He hasn't even matriculated yet. He's like, "Why do I have to work 60 hours a week in residency?" Like, oh my God, 60 hours. You know how hard that is? I'm like, oh my God, bro, are you serious? Like, are you like, you haven't even seen, and I can't wait to start hazing him. Uh, just giving him a hard time. Already, he's talking about, why do I have to work that hard? And I mean, I don't think I could be a program director because I just can't. I can't. And any student that I talk to at the end of the rotation, student or resident, especially students, at the end of the rotation, I give them the same sermon. Literally, I said, "Do not get caught up in the culture of entitlement. The world is not waiting for you to graduate medical school and become a doctor. Nope. The world wasn't waiting for me. It's not waiting for you. You got to go get it. And so you don't deserve to be where you are. You were gifted this position and you better never take it for granted."
No, it's definitely, it's always good to look back in a sense, and remember where you came from. Obviously, always having a vision on where you're going, but always remember, where you came from. And I remember, I paid off my Sallie Mae loans. I had
I had Sallie Mae too.
yeah, I saved a lot of money, and I've started paying off in chunks because one of my children graduated college, but I was used to paying tuition. So I'm like, well, I have this money that was earmarked, whatever. So let me just pay off. So I pay off my Sallie Mae loans. And the Sallie Mae lady said to me, "I'm so sorry you had to do this." And I said to her, "Are you kidding?" So I write that check for $1,000 a month as I have for every year for the past 15 or so years with a giant smile
Yeah.
on my face. Said, I love my life. And you know why I have that life? Because Sallie Mae loaned me the money to go to med school.
Yep.
And she said, all right, I'm gonna put you on hold. I'm gonna start a recorded line and you're gonna do all that again. But yeah,
100%.
it's real. Listen, we help a lot of people. I think we help a lot of people we never knew needed help. And for me, the cool part was helping people they don't, whatever, 90% of the time the patients don't even know us anyway. So that's
Yeah.
the
Yeah.
that's kind of the best part, right? We're in there doing our job because it's what we're supposed to do and it's what the patient deserves, but they don't know us. But we do good work, and the patients that are destined, the thing I say to my families is, listen, if your loved one is destined to survive, then I can help them to survive. If they are destined to not survive, however, there will be nothing I can do despite the maximal aggressive care. And the other side of that is, right, we suffer serious loss every day we come to work. We suffer serious loss And I've known you over the years, and you're very emotionally invested in your patients. It's what makes you such a good and kind physician. And it hurts, right? It hurts when you lose that patient you've been caring for 2 weeks, 3 weeks, 4 weeks. And we have to figure out, right, how do we honor the patient? So this patient that we've really come to know and like, this patient died, or we were very similar. I was in private practice for 15 years as well, like you were. Even worse, your patient of 7, 8, 9 years that you've known dies. So we have to be reverent, honor them, pay respects. But at the same time, I have 18 other critically ill patients on life support that need me in the next 10 minutes. So how am I going to compartmentalize my grief and my emotion so that I can go and be, super sharp, super focused, and take care of the next crisis? So that's why this job picks the people, specifically the critical care pulmonary. It picks us because it's not survivable by, in quotes, a normal person. It's just not survivable. And then to go home, right? And then take that then you want to go home. You can't be miserable to your family. So somehow we have to figure out, okay, so somewhere between walking out of the hospital and driving home, I got to be husband, father, put that smile on my face, and not to be fake, but also they don't deserve to come, I come through the door, be like, oh my God, I'm like, Eeyore. Oh, you wouldn't believe what happened to me today. All the people, it was terrible. They don't need that from me. I'm the.
Oh, you're right about that.
So that's why, like, all these things, right? They come around, and the job has to pick us because there's no other way.
I love that. I love that the job picks us, and I have that. We have that in our tradition where it says everyone in Arabic it says kullun muyassar lima khuliqa lah. Everyone's path is made easy for that which they were created for. Right. So you and I were both created to be critical care doctors, and on our path, just you're look at what happened to you. The similar thing happened to me, very similar. I remember I was talking to the advisor at Marquette, a pre-med advisor, and I'm like, you know what, I think I'm going to apply this year. I have everything in, and she's like, you're not going to get in. Like, my face, you're not going to get in. You have very little chance to get in. You should wait and early decision next year to whatever. And I was dejected, and I'm walking home all dejected, and right there happened to be my co-RA was walking home with me. He was already in medical. He had already got accepted. He's like, "What's wrong?" And I told him the story. He's like, "Don't listen to that bitch. She doesn't know what she's talking about, right?" And I'm like, you're right. What's the worst that can happen? The rest is history, right? And so every time every time I strayed, the Lord sent someone to push me back on my dad's thing. I thought about, what, I'm just gonna this path is difficult. I'm just gonna become an engineer. I was biomedical engineering. I'm just gonna become an engineer. My dad said, don't. He is an engineer. He's like, don't do that, son. You've only ever wanted to be a doctor. Don't give up. And and again, the rest is history. So I think, I love that the field picks us, and I'm super grateful that the field picked you. I'm super grateful that you are my partner. I'm super grateful that you're my friend and my colleague, and I think we're going to have more of these conversations going forward. I'm grateful to be where I'm at, and like I said, I think I am super happy to be counted as your colleague and hopefully your friend.
Absolutely, man. I definitely feel the same. You're, especially through your writings. I started reading your writings, and I thought, oh, this definitely vibe with you in that regard, because that's what we need in medicine, right? We need that spirituality, because it is the people have souls, right? So it is more.
Yep.
The person is more than their disease, and I've always picked that up from you. You always see people as people and not just a disease state. Again, one of the many things that I find inspirational from you.
Oh, you're super kind. You're super kind. So, Dr. Solomon, it's been an honor and a pleasure. Thank you so much for your time, and until next time, I have a sense we're going to have many more of these conversations going forward.
All right.
Take care.
I will look forward to it. Have a great day.
You too.
All right. Bye.
Thank you for listening. To get every episode delivered directly to your inbox, please subscribe at healthcaremusings.com.